this episode of Talk ADHD is really important. In it, Andrew is sharing his experience as an ADHD practitioner and clinician working in the NHS, working for providers within the right to choose pathways, as well as running his own private practice, Divergence. And he's sharing the most common frustrations, hurdles, and challenges faced by your clinicians when trying to provide the best and safest care for you as new patients, particularly when we're in titration for new ADHD medication. I really hope that what you take from this is some understanding of the simple things that you can do that can help your clinician provide you with safe care. So sit back, relax, and enjoy Talk ADHD. Welcome back to Talk ADHD, Andrew. We are back, and this is going to be a really useful follow-on episode to the two-part series we've just done on medication from the point of patients and people being assessed and diagnosed with ADHD. And here's why. For those of you that don't know, and if you've listened to this podcast for any amount of time, you do now, Andrew is an ADHD clinician and has ADHD. Just let that one sink in for a minute. Andrew is an ADHD clinician who also has ADHD, as do others in his clinical practice, as do, for that matter, probably more clinical professionals than most of us would care to imagine. So this episode is about relationship management. This episode is about how, as patients, can we get the best from our relationship with our clinicians wherever we have been assessed and diagnosed to ensure that the support and the ongoing care and treatment that we receive from them is the best for us. Now, in order to do that, this conversation is going to be very much from the point of the clinician, from Andrew's perspective, from the things that on a day-to-day basis cause difficulties or challenges or problems, and at their worst could lead to somebody no longer receiving the care that they need from that treatment because of breakdowns in communication. So Andrew, this one is for you and everyone else on your side of the desk. And I'd like to start with asking you a broad question, and it is one of those questions, but I think it shouldn't be as bad as normal, which is, in your experience and talking to other clinicians, are there very common things that we as patients do or don't do, really, that make it difficult for you to do your job?
Yeah, of course there are. Of course there are. I think people forget that we're all people sometimes, that there's an expectation that a service will deliver an outcome, isn't there? You know, I've come to you to get this sorted out, so fix it. But I'm yet to meet someone who's walked into a garage, having taken their car to a garage to get it fixed, who's achieved getting their car fixed by saying, here's the keys, fix it.
Okay.
It's not the way to get things done. But to answer your question, I think in ADHD practice, yeah, there are some key things that get in the way of providing good quality care. And do you know what they are, Matt? They're the symptoms of ADHD, aren't they?
Now, you see, we're straight into the heart of the matter, aren't we?
Yeah.
Yeah, they are. I mean, let's not beat around the bush here, shall we? Yes, the things we're going to discuss are very much the reasons most of us have come to the people like you in the first place, because we're struggling with, we find this difficult, we don't do that very well, help. But I think perhaps this conversation is to highlight the fact that just because we've made the appointment, just because we've got to the point of being in titration, doesn't mean that's where things stop. Now, we've discussed this from patient point of view many, many, many times before, but this is about how those things are still impacting. So I guess we are in the realm here, broadly speaking, of executive dysfunction. We're in the realm of those of us who struggle with inattention and perhaps some of the hyperactive mind, but we'll maybe dive into that and the connections to that later. I come to you for an assessment. I throw my brain's car keys at you, desperate to say, fix that. You do the best job you can, and you get me through the pre-diagnosis, through the diagnosis, to the point where you said, this is what's going on with your engine. And here is potentially an ongoing plan that could improve that, make that better, if. And it's in, I think, the if framework that if I'm understanding you, things start to fall apart. Because it's in that framework of communication, of giving you the information about what this means to me, that you need to do a responsible job that causes you challenges. Would that be fair to say as a starting point?
Yeah, so there's lots that we need to know and understand to keep things safe, to keep problems that could commonly occur if we don't know stuff away, and to prevent things going wrong. So we ask a lot of questions. That applies across all ADHD services, and I've worked in all sectors with all ages, and we can't explain everything to everyone all the time, and there is this sort of perception that an ADHD service will do X, Y, Z, and that comes sort of almost like a group understanding of what ADHD care is like. But that is based on people's experience of what other people have told them about ADHD service. A key one that often comes up, a key problem in practice, is people being annoyed that they've been discharged from a service because they've missed appointments. That's a really, really common occurrence, or they've forgotten other things. But it was one of the first times I became aware of this issue of ADHD service design and how important it is. It happened in the NHS that someone, the NHS across the board, there's this sort of usual rule. It's a sort of common accepted practice. If you miss 2 appointments, then you don't get a third. That happens in all walks of NHS practice, and it happened to someone in the NHS service I was working in, and I thought, hang on a minute, there's a clear reason why that happened, and it was about their ADHD, but they were discharged. And now if you get discharged from an ADHD service in the NHS, that's a long wait to get back through the door again, isn't it?
We're talking 12 to 15 years, depending on where you live. That's an expensive missed couple of appointments, isn't it?
Yeah.
Okay. Now, anyone listening to this may have had a reaction to that sort of story of, but that's me. I miss appointment. I've missed appointments, right? I know I have. I've spoke to multiple people this week mentoring them who've said that's one of their biggest issues. I forget things. And yet, here is one of those core things that we're trying to improve in our lives by coming to someone like you, whether it's NHS, right to choose, exclusively private, it doesn't matter what. We're coming to someone hoping for resolution or improvement, and then all of a sudden, because we aren't there yet, you're at the back of the queue again. Okay. I'm not going to go too far into that for a minute. So that's number one, we miss appointments. What else is it that we are doing or not that is making it difficult to provide, and I like the framework of a safe service for people?
So it's getting frustrated with the questions that are being asked, which comes across as people thinking they know. And sometimes they do. Some of it is frustrating, but sometimes people come across as thinking that we're not understanding because they know better. And actually, the process is there to support you and make it safe for you. And you don't need to understand all of it. You don't need to be an ADHD specialist to have ADHD care. You need to have a good ADHD specialist to guide you through that care. But I suppose we're in a situation where there's a huge range of quality of care, isn't there? This is why we do this podcast, to inform people and help them navigate that. But one of these huge barriers is, well, I know better than you. It comes across as, I know better than you. I shouldn't have to do this.
Now, can I just qualify that? Is that at every stage of the process, from sort of pre-assessment through to diagnosis, or are we talking purely in titration? When are you experiencing that kind of, I know more than you, just sort it out, Gov?
It largely happens in titration, particularly in the early stages of titration, where someone's not got a lot of experience with these medicines and they're doing something. We talked about this on the medication episodes. That those first few days of stimulant, often people have really good response, and then they make the mistake of not following what's been prescribed going forwards, and then have horrible reactions because I'll just take twice as much if it's not working. But those sorts of things, those mistakes are personally costly, but also dangerous. For all we're just asking some repeated questions, we are looking out for some very key indicators that things aren't going well. I can refer back to that rainbow that I've shown on previous podcasts, keeping people out of the warm colors of the rainbow on that spectrum of dopamine intensity. A lot of the questions that we're asking about are looking for markers of that. And we don't need to explain to people what those are. We just need people to answer the questions, and then if they come up, then we can explain. Otherwise, we're teaching every patient to be an ADHD specialist, and you don't need to be. You need to be a specialist in your own ADHD, not everybody's.
Now that's interesting, because that's sort of the mirror image, I suppose, of something that you have said many times before, which is that you're very open, and a good clinician should be very upfront about the fact that the person who is the specialist in how ADHD affects them is the person coming to you for help. But the person who is the specialist in how to support, treat, and prescribe for ADHD is the clinician. And yes, that's a conversation, and that's a mutual respect that says, I can't tell you what ADHD is for you. I can work off generic. I can work off what we've got from research, but it still isn't what's going on in here. But I do have the training, the qualifications, the expertise to guide you safely. Now, I think one of the things that's just popped up into my mind is, and again, I see this an awful lot online. We see all the YouTube medication diaries, and we see lots of people sharing their experiences. We've spoken a lot about getting people to a point with medication where they have more agency over what medication means to them. Right. So when we've got to that effective dose and stable dose, that they're able to say, well, not today, because I want to be a bit more, whatever it may be, for my medication. But in that initial phase, right, you are going to start medication, and this is titration. Are we talking about people who perhaps maybe might take it once or twice, think, oh, I didn't like the way that felt, and then I'm not going to take that, and then wonder why when they have a review, you might be looking at them slightly more confused, going, I don't know what you expect me to tell you. I've got nothing to base this off, because you didn't do what was on the bottle. You didn't take it once a day for X amount of time. Is that the realms we're in?
Very much so, yeah. I have an appointment with someone tomorrow to have exactly that conversation.
Okay. Now, I mean, forgive me, I'm maybe in a slightly different place. I have the privilege of working with you, learning from you, and hopefully thinking about this differently, having got a family through it. But my brain doesn't compute thinking I would know more about how and when to take medication if it's something I'd never taken before, to the point I would choose not to take it because it gave me a headache, or it made me tired, or whatever else it may be. I don't compute that, but I know that is out there. I have had conversations with people who've said to me, yeah, but why? Why do you have to follow a prescription? Now, my response to that typically is, if this was any other medication, for example, the one that comes to my mind is sort of diabetes, for example. If you didn't know you had diabetes, and then you are diagnosed and you know you have diabetes, and you're told, look, there is this insulin injection and you need to take this. I can't believe for a minute anyone in their right mind would go, nah, that can't be right. I don't think I'll do that.
Well, you'd be shocked. There's research to say that they do. There's research going back years, and it's been repeated, so it's clearly valid, that at least half of prescriptions written aren't taken as prescribed. At least half.
Now, I'm going to split that half into half again. I'm going to say, let's look at, I hate a word I hate using, but neurotypical, people without any other reason, right? Let's call it their own belligerent substance.
I'm not just talking about prescriptions for ADHD
here. No, I'm not either.
I'm talking about prescriptions for everything.
Yeah, no, I am as well. I'm just wondering whether we go back to, so let's say somebody with ADHD is prescribed a medication for anything, right? Antidepressants, antibiotics, call it what you will. Going back to what we said at the start, how much of this falls under the realm of I think I know better, or potentially this is my ADHD that just makes it difficult to do things regularly in the first place, let alone remember to take a pill.
Wow, that's a really good question and really pertinent, isn't it? Because I'm saying lots of this comes from ADHD, but actually, you just made me quote this research that says half of people don't take medicines as prescribed, and that's people. That's not people with ADHD. Therefore, this is something about people, isn't it? This is not something about ADHD, although ADHD can amplify that.
It's really interesting sort of dichotomy for me to go, are we just a weird species? That I have a problem, we go to someone we are told is a specialist who we believe and trust can fix it, and then, for whatever reason, just don't do that. You know, it's kind of like, go back to your car analogy again, right? It's like having your car fixed, diagnosed, and being told, now look, this is a Ford Fiesta, not a Land Rover Defender. Please don't take it green laning because it will break. And we going, I'm going green laning. Oh, my suspension broke. Did it? Is that what happened? And then going back to the mechanic and kind of going, it broke. Well, yes, it did, because I told you not to go green lane, right? It seems very similar.
You should have put better suspension on it.
Right, now then, that's where I think we're coming to. Right, so I know you, I know Divergence, I know your team. I know the processes you have in place and the efforts you go to try and explain everything as simply and clearly as possible so that people know what is going to happen every step. And yet I know that people don't. And at this point, I'd like to hold my hand up and say, yes, even I have not responded to emails from Divergence about feedback from my son, and neither has my son. And so I am not excluding myself from this really odd conversation here. Right, I have to show some humility and go, yeah, me too. And I don't even know why, but it wasn't deliberate. But the question is, if you put all that effort into explaining it, and you make it as simple as possible, and then you still don't get that information, going back again, at what point, whether it's cost, whether it's time, whether it's a combination of both, do you as a service have to say, this can't carry on? At what point do you have to take the very difficult decision that says, we cannot keep chasing you? Even though we understand ADHD, we do not have the capacity to keep chasing you, and therefore we won't.
So I wish I had the answer to that question. And I think every ADHD service in the land probably wishes that we had the answer to that question on this podcast. But part of the reason for setting up our own service was this, that we saw people with ADHD struggling to access ADHD services in other services we've worked for, hitting barriers that seemed quite driven by the symptoms themselves, and we wanted to understand it differently. So we have quite a high tolerance for people not responding to emails because we want to understand. But other services don't. Other services haven't got the time for that, and they've got a queue down the street of other people who quite happily fill that appointment you've missed. And they haven't got the resources, particularly in NHS teams, to say, it's all right, come next week, and then for next week to be missed as well, because that's now 2 appointments that someone else who's standing in a queue of thousands could have used. And there has to come a point somewhere where in services where there is high demand, don't have the luxury that we have to be accommodating and understanding and supportive in the way that we are, to say, well, it's okay. You know, we'll find another way around it. But that's because our service is designed in part to explore these ideas and understand what's going on. But you're right, at some point, the guy who keeps coming back to get his suspension fixed, saying it's our suspension parts that are wrong when it's actually how he's using those when he takes them away from the garage, has to be held up and said, look, we can't keep fixing your car like this. We're not helping you. You know, you're just breaking thousands and thousands of suspension units for your Ford Fiesta, and that's costing you a lot of money, and it's costing us a lot of time. What's going on here? So it's an ongoing conversation that we have with lots of the people we work with, but going back over a decade, it's an issue that has hit ADHD services and driven these sort of quite harsh responses, like if you don't respond to us, we will close your case and put you at the back of the queue, because the demand is so high.
Oh, yeah, absolutely. I'm going to go off on tangents briefly, so I apologise to everyone listening, watching. I'm going to try and make this congruent. The first thing that's just occurred to me in listening to you and thinking this through is, we have said before that the NICE guidelines, so National Institute for Clinical Excellence, and there's that word guidelines, say treatment of adult ADHD needs to be multimodal as an approach. Yes. And I am now sat wondering whether it's the information about how important all of this is that we don't get or know before we even get to our first assessment, that then creates a lot of these problems, even if we get to the point of being fortunate enough to have a diagnosis and having someone trying to titrate us onto a working and effective dose of medication. I'm wondering if it's almost a lack of awareness, knowledge from credible sources that's causing that problem. Because I know that when I was researching my ADHD, I watched hours and hours and hours of content and listened to hours and hours and hours of content about what ADHD meant to someone else, right? The kind of stuff that we're swamped by. I cannot genuinely think of a single piece of content that really spelled out to me how important the relationship between me as a person and a clinician maybe. That was something I had to figure out for myself in that process. And you're right. I mean, I was fortunate enough to go private with another clinic. They didn't have time to spend, my appointment was about a 90-minute appointment for assessment and diagnosis. They didn't have time to tell me in that appointment, by the way, before we start, you'll need to do this and this and this, and you need to have systems in place and you need to have processes in place. And none of that. They didn't have the time for that. And I don't think that was a point of lack of responsibility. It was time constraints. And I understand that. But I am beginning to wonder whether that's a missing part of the puzzle. That people just don't appreciate how hard your job as a clinician is going to be if the information we are sharing and the responses we give you are not timely. Don't answer the questions you've asked without expecting that we know better, and done when you ask for them. Because something we've discussed a lot is during titration, you ask for feedback every week, right? You recommend people start their medication on a certain day, and you ask for feedback on a certain day, right? For everyone. Now, I understand why. Didn't do it, but I understand why. Right, sorry. But I think the thing here is, I've never questioned why you needed that feedback. I've just let myself be rubbish and not do it. Am I hearing you right earlier on saying that there are those people that question why you're asking the same questions in the same way week after week after week?
Oh, yeah.
And do you think it's because they think they know better, or those questions are irrelevant?
So I get responses like, I've already told you this.
Right.
Even though it's a week later and they're taking a different dose of medication, and I'm trying to understand a difference and measure it against what you told me last time. Because if it's the same, then we're probably not achieving what we're aiming for. But I've already told you that. Told you my weight last week. Yeah. But that was your weight last week. What's your weight now? And that's sort of an easy example to give about weight. But there are lots of questions where we ask the same thing repeatedly to find out what the difference is between the time of asking those questions. And an enormous amount of people get frustrated by that. Why you keep asking me this?
What's up in that for you? Do you think it's because it feels irrelevant? It feels repetitive? Is it because they don't understand that you need that information to make a cumulative, ongoing assessment decision to be able to prescribe safely? What's the block?
I wouldn't like to presume. I know that information is provided in writing. I know it's provided verbally. And I know that it's reinforced with reminders. And I think there are a range of reasons why that isn't important to the person who's going through the process at that time. There are more important things. There are distractions that pull you away from thinking, yeah, I better tell Andrew this, for long enough to be able to actually communicate that. And if you map that out into services that are busier, that don't have, I'm not saying we're not busy, but that don't take the time to put value on this and understand what's going on, you're going to see a lot of people who don't get a positive response out of treatment or even lose the service altogether.
I can see that. Do you think there's also risk in that means that some services, perhaps, how do I phrase this, are now almost a bit more factory-like in their process, and that the level of treatment, support, care isn't as detailed, and that they're not asking for as much regular feedback because maybe they know, maybe they've experienced that we're not going to get it. Dave thinks he's on his working dose until he comes back and tells us what he perceives is a problem, and we'll charge him for a follow-up appointment. We'll move on to the next person in that queue of 15,000 who've been referred to us under, for example, NHS or Right to Choose or whatever. Do you think there's an element of that could be happening as well?
Yeah, it's very tempting to think like that, and you can design, as much as you can design a service to say you can't have a third appointment if you miss two, and that is something that happens across the NHS. Services can be designed to respond to how people are using them and are. And I've seen that response. I know that the issue you're talking about is a key concern for the Care Quality Commission in ADHD services. This idea of what happens between appointments, how is safety maintained, is really important. And the CQC inspection will be looking at what's happening between appointments, what risks are being taken, and how are those being managed. And if someone isn't doing what they're asked to do to make that care process safe, and the service isn't doing anything about it, the service gets criticised.
Another question
that's what, before you ask that question, that's what drives, well, you're discharged then because we can't help you. You're not ready because you're not ready to use our process.
Yeah, you can't do that. No, that makes sense. This is the question that's just occurred to me, and again, and when we've sort of spoke about this from patient point of view before, is we talked, I think it was last week, about patients whose feedback is, he didn't do anything. I didn't. Now, we tried to get this across last week, and so I'll reiterate it. Yes, it did. There's always a something. You just need to think about what it was you thought it would do and whether it did. That is my start point. What is it you thought was going to happen that hasn't? Right? Have you magically tidied up your bedroom or never missed an appointment, for argument's sake, right? But do you think that then also drives a lack of communication from people when they think, well, I've got nothing to tell you because it didn't, even though you're asking them pre-formatted questions which lead those responses?
Yeah. There's that. There's, I didn't want to bother you with that. I know you're busy, or I didn't think that was relevant. It's always relevant. If something happens, I would always rather say, no, that's got nothing to do with the medication, than answer a coroner's question as to why that happened because someone assumed it wasn't the medication. That actually there's, even if it is left field stuff, and you think it might be related to the medication, I'd sooner say, no, it's not, than have to answer to somebody else because it blatantly was, and I didn't know about it because I was left to be somehow some kind of telepathic clinician that knew that this was going to happen, because we don't know what's going to happen when someone takes a medicine, any medicine.
Well, you've just teed up what I was going to come on to next. I mean, there's this sense I'm getting as we're talking, perhaps not just within ADHD, but within all patient-clinician sort of relationships, that it almost feels like there's an expectation that you do read minds, that you just know the answers, you know what it's going to be like that, because there's an expectation sometimes, which is misinformed, which isn't accurate, that these medications will have the same effects for everyone. So if I'm taking my 56 milligram dose of X, and so's my mate Steve, and Steve said it did that the interpretation is, well, it'll do that for me, therefore I don't need to tell you. Does that make sense? That this sort of...
Of course it does, yeah.
And yet the reality is we are talking about personalised, very important to the individual care and processes. And without the information about you, how on earth can any clinician know what's going on for you? Right? It also throws up another question, which I think is really important to put into the mix here. You and I have discussed again coexisting conditions at great length. We're talking about future episodes where we talk about coexisting conditions in more detail. But as a touch point here, we also know that frequently and often during titration is when other, whether they are neuropsychological or mental health conditions, may start to present differently than they've ever done before. And whilst they are looked for in assessments, if you are not getting that right level of communication and information from your patients in the way that you're asking for it, the risk is for you that you can't join the dots, that you can't
That's right.
say, oh, wait a minute. Is that right for you?
But yeah, very much so. So, you know, when we're titrating an ADHD medication, we aren't just conducting the dopamine receptors. Do you remember the conductor analogy we used? That the conductor isn't just conducting that; it's conducting the whole choir. We're looking for what's happening as those serotonin, those dopamine and noradrenaline levels go up. What's happening around that whole system, because it's all interdependent. So yeah, we do see changes in anxiety, in other mood conditions. We do watch out for destabilization of potentially an underlying bipolar disorder. We look at the impact of that improvement in focus and concentration on sensory sensitivities. And we try and do that in as unintrusive way as possible by asking some really basic questions about what's going on. But people think they're just throwaway questions. I shouldn't have to tell you that. But you've changed your medication, and you've changed, therefore, those concentrations of those neurotransmitters, and you just expect me to think that that'll be all right. If it was that straightforward, and I've said this facetiously in other services before, if it was that straightforward, you could go into Tesco's, like you'd get your passport photo, you could answer some on-screen questions, you know, probably 18 of them, put your arm in a machine, get your blood pressure checked, and it would spit out a titration pack, and you could just go whoop right up to 70 milligrams of Elvance or whatever, and away you go. That's brilliant. That's my ADHD sorted out. And ADHD ain't like that. It takes work.
And don't we know it?
Hi folks, it's Matt. Sorry to butt in, but I'll be really quick. It would really help us if you could take a minute to do a few things to help this podcast reach more people. Wherever you're listening, if you could like it, assuming that you do, if you could subscribe wherever you're choosing to listen to this or watch it, and if you could jump onto the YouTube link and leave a comment about the episode that you've just listened to, Andrew and I would really appreciate it, because that all really helps this podcast reach more people. For now, I'll stop waffling on and we'll get back to it.
It's interesting. The more we're talking about this, the more I'm beginning to think this is perceptions of, again, patients, perceptions of what's important, not aligning with what's really important. Patients' perceptions of what information they need to give you or could be bothered to give you or whatever it may be, not being the same as what you actually need to do your job well. And yet that's not the same for everyone. I don't wish anyone listening to think I'm tarring everyone with the same brush. And I'm going to sort of switch this conversation in a minute to be more sort of into part of the work I do, which is in mentoring people. And imagine, okay, if somebody came to me and said, Matt, I've just been discharged from a service because I just couldn't, what would I suggest? So I'm going to try and do some of that in a minute. But it's fascinating. So we run our community Talk ADHD. And there was a message on there this morning that was a comment about the last episode. And there's a line in it which really struck me as just somebody really getting it. And the line was, something that impacted me about last episode was how important you are to your own experience of the medications. In fact, they're nothing without you. I think that is such an incredible way to view it. It is spot on. Every one of us is vital to our experience of medication, but we cannot keep that to ourselves, and we certainly cannot keep it from the very people that we've approached to help us manage that and to help us improve the challenges that those things have thrown up to us. We need to be sharing frequently and often, and when asked, all of our own individual experiences with our clinicians so that they can keep us safe. And I really want before we switch this to hammer that home, everybody. The job, as Andrew has said, of your clinician who is prescribing what are described and labelled as controlled drugs for the most part, is to keep you safe. Yes, it's to help you improve your life. Yes, it's to help you get a handle on what ADHD means to you. Yes, hopefully it's to improve things that you may have struggled with for the entirety of your life. But it starts with safety. No one else's, yours. And without communication, without that relationship remaining intact, it is nigh on impossible for your clinician to be able to keep you safe effectively. Would you say that's a fair statement, Andrew?
I think it's a fair statement. What was going through my mind when you were saying that was an answer to a question. I don't know whether I answered it previously, but I think you asked what's some of the most complicating coexisting conditions in titrating someone on ADHD medication, and I know the answer to that now. The single most complicating condition that happens in ADHD titration is humanity, that the patient is human and that we make mistakes and we make assumptions, and that the clinician is also human, and that somehow gets lost and forgotten, which is why I was in that episode where I was saying ask questions. That isn't just about to gain information, it's also the asking of that question encourages communication. It invites people to understand. Expressing frustration doesn't. Expressing frustration leads people to be defensive. But if you ask a question, why do you keep asking me those same questions over and over again? I'll tell you. I'll explain exactly why and which one is it that frustrates you the most. Why do you keep asking me my weight? We don't have to ask that every week. If it's an issue, we can talk that through. We can solve that together. But if you just say, I'm not filling that out because you ask me my weight every week, we've lost. So I think what often gets lost in discussions about ADHD, whether it's about the titration of medicines, the assessment of the condition, is that it happens in humans and it is cared for by humans, and it exists in a society full of humans first. We are not ADHD first, we are human first, clinicians and patients. And if we lose sight of the fact that that clinician is a person, or that clinician lose sight of that patient is a person, and both have families and both have life outside of that, and both work in imperfect systems where things go wrong and mistakes get made, and we do our best, patient and clinician, to mitigate for those things going wrong. We can be more collaborative, more supportive of one another, rather than you are my clinician and you will make my focus improve. That's not how this works.
No, and again, that's an important thing, isn't it? You are not there to make anything happen. You're there to facilitate the things people are looking for. Now, you can only do it as a clinician based on your expertise and your practice and your knowledge and what you know of the condition and the diagnostic criteria and the treatment and the medication and so on. Without the relationship, without the human part of the person you're trying to treat, that is an incomplete process. It's an incomplete way of looking at it. You have to know how it's affecting, what it means to that person to be in titration, to be given a prescription, to be asked to meet demands. But you're right, it does come back to this, starting with the fact that you are a human with a wife and children and a business, as well as a family and everything else between, as are all your patients. And sometimes we have to remember that we're talking to another person.
I think so. I really feel for the clinicians that are working in NHS services that have got these huge waiting lists. Think about, when you get to the top of that waiting list and you walk through the door, every person that walks through that clinician's door is furious that they've had to wait years, and they've got horrible stories of what's happened in the years since they were referred for that assessment. That impacts on the clinicians as well. We're not sitting here going, this is great. That's not what's happening.
Yeah.
Even the less engaged clinician still goes home at night and goes, oh, that was intense. Day after day of people saying, oh, at last, and all these expectations coming from social media, it drains you. It's hard. It's why I'm not in the NHS anymore. Working in that environment where people are just hammering it all the time. I've had this horrible experience, as if it was something that I'd done. It's hard.
Yeah, and I would echo that definitely within the NHS, and I would say that, even for you in private practice, people go through right to choose. The person you're sat in front of is a person, right? Now, it's about recognizing that there's load and demand and overwhelm and Lord knows what else on everyone. It is also not the clinician's fault that there's a 12 to 15 year waiting list in the NHS. It is not the private clinician's fault that they do need to charge you money to provide a service. Right? Is there a disparity between how much different services charge? Yes, of course. Is it standardized? Can it ever be? Probably not. But again, what they're trying to do is provide the service that you have asked for. Starting that on the defensive will never result in the best care for you. It can't, can it? Because again, we're humans. Okay.
I think it's driving a lot of these service responses. That actually, okay, then, if you can't send that feedback, we will discharge you. If you miss appointments, we will discharge you, because we can't engage in the humanity of why you've forgotten that appointment, why you're not sending that. I haven't the time, because there's a queue of angry people wanting to get into that appointment that you've missed.
I agree. I completely agree here. Right. Okay. So I think what we need to do here is answer a fundamental question, Andrew. Having said all of that, having you shared very honestly and vulnerable the challenges, the frustrations, not just of your own service, but of NHS and right to choose and everyone else, and we've tried to be, realistic about the challenges for people with the burning question, I suppose, for most people will be, yeah, but so what? Right? What does that mean then? What am I supposed to do about that? Okay, here is my interpretation of so what at this point. So let's start from clinic side. Whether that's NHS, whether that's a right to choose provider, whether that's a small independent private provider like yourself. The so what is you are doing your best within the constraints and the confines of the procedures and the processes and the facilities that you have to provide the service and the care that people are asking you to provide. And yes, that's going to be different depending on who you see. And yes, there may be variations, but you can only do what good looks like to you if the people that you are seeking to help understand what it is they need to provide you with, what their role in this relationship is from the outset. We've said this before, it's why we are doing this podcast, to try and get really useful, actionable information out there. So from clinic side, it's about understanding that, as you have said, you are treating not just people, but typically people who are struggling at the point they are coming to you, or people who've been struggling for years by the time they reach a diagnosis. And that inherent in that may be a long time, if not a lifetime, of finding the executive function challenges that we are discussing make this a problem really difficult. That they may have not followed through on taking a course of medication that was prescribed by the GP before, and that there is a risk and a likelihood that they will do the same during titration. So from clinic side, it's understanding the limitations of your machine and communicating exactly what it is you need to your patients as early as possible, and making sure that they are A, on board, and B, genuinely do understand. There will inherently be differences in approaches, right? Whether it's emails, automated emails, apps, whether you have an army of secretaries or not, there will be a difference in the way services communicate with their patients. But communicating what that's likely to look like and what's required, I think that's the so what from a clinic side. Is there anything you would add to that first before we go on to us, people with?
It's remember that we are people too, and that however a service is designed, it won't always fit. It's possible to offer tailored care, but it's very, very expensive to do that, because if I'm caring for you in a personalized and tailored way, the way you want it to be, I can't be doing that for anybody else at the same time, because you wouldn't want me to do that. It's how hospitals work. We gather together sick people and provide care in an efficient way. And it's the same with ADHD clinics. There has to be a level of process and efficiency in order to provide it safely and in a standardized way. And then what happens is there are different levels of personalization. That is the art of good healthcare management, is making that process as personalized as possible. But it's never possible to make it personalized to every individual, because that's not what happens. You can't do that because everybody's different. That's why the most problematic coexisting condition in ADHD is humanity, in terms of how we provide a service. Yeah.
I'll take that. Okay, so let's now switch this. So what does this mean to us as patients, no matter where you are? Well, for me, what it means is this. Remember that sounds a bit woo-woo, but this is a journey to go on. From the minute you think, is this ADHD, to the minute you put yourself on a waiting list or book an appointment, you have started a journey that you likely never expected to be on, probably didn't ask to be on, but have decided is important to you. And once you start that journey, what's important is understanding what each step of that journey not only looks like, but will need from you. And again, that doesn't matter whether your journey involves waiting for 10 to 15 years for an NHS assessment, going through right to choose and expediting it with one of their preferred suppliers, or going to a small independent private clinic like Divergence. What matters is that you understand what that process needs from you. That you understand that it's not simply about fix me, I want to go green laning in my Ford Fiesta, right? It's about what does fix me look like? What does help me look like? What does help me understand me look like? And that involves a lot of work before, it will involve a lot of work during, but it will certainly make a difference if you are asking the right questions of the right people at the right times to know. Now, what's very important to say is this. This is where the role of coaches or mentors or peers or advocates come into the equation. Because yes, there are people like me who have been through this process, who work with others in going through this process, and who have clinical partnerships like I do with you, who can guide you and perhaps give you tools that may support you to not be the person that forgets the emails or misses the appointment, despite the fact I haven't. Yes, I know, there's the oxymoron, I do it myself. But what we're going to do next episode is this. We're going to follow on from this. And I'm going to try and have a think about the most effective tools, strategies, and approaches that you can take as a person at that part of the process that will not only help you get the best, safest care, but that will also help you be less at risk of being that person that could be discharged from a service because we've missed one too many appointments, we haven't given the feedback that was required, and therefore the clinician that we have chosen is saying to us, I cannot do my job safely. So I'm going to give that some thought, and we will come back with an episode that shares some of the most useful proven strategies that can help. And yes, they will all be based in the realm of organization, executive function, managing overwhelm, and managing our emotional reactions to the kind of things that are being placed upon us at that point. But for now, I hope what this episode has given you is a sense of just how important this conversation is for your clinician, just as it's important for you as a person investigating what ADHD means to you. And as Andrew has said, your clinician is a person. Your clinician may well be a person with ADHD. Your clinician may be a person with ADHD who gets triggered by RSD when people don't respond to them in the way that they should, and they think, is it me? So what I'd like to end on is this. Yes, Andrew, you're spot on. The biggest issue we have in this is humanity. We are a strange and wonderful and weird and frustrating creature. Our brains are multifaceted. Sometimes they're wonky and sometimes they work in perfect straight lines. But this is a process of working with a person who wants to help us, but remembering that they're a human who's got to follow certain processes and guidelines and rules and regulations, and that it's our responsibility as a patient to help you do that to the best of your ability. Fair?
Yeah, it's the other side of the coin, Matt. That is not all of it, but we've already talked about the other bit.
Yeah. We hopefully, I say this so often, I hope that what this podcast is different. And I hope that it helps people sort of figure out what all this involves. And we don't have all the answers. We're figuring this out between us and trying to share best information. But go back to the previous episodes, go back to the medication episodes, go back to the what does a good assessment episode look like. And within all of those and these, you will find hopefully information that helps you understand how to get the best out of this process at every stage. But on that note, I'm going to say thank you very, very much for listening. We will see you next week when I've been able to scratch my head and figure out what actually might help. But until then, this was Talk ADHD. Andrew, thank you for being so honest, for being so vulnerable, because that's what people need.
That's okay.